whether a number of different intervention factors, which included standardizations and education and training programs and rapid improvement workshops and roundtable meetings and work groups and pain champions and electronic notes and all these different things that occurred over this 4-year period, whether they would have an impact on the extent to which providers were doing concordant care. So whether they were doing what you were supposed to do for opioids. So when we look at our results over time, what we found was three things particularly. The first of those was that prescriptions for opioids for individuals that had chronic opioid care, which was greater than 90 days, decreased over that time period and remained relatively stable for those that were receiving less than 90 days. And the other two factors were that the concordant care important things are whether individuals have an opioid agreement, that is, whether when they go in and they receive their first prescription for opioids from their doctor, or at any point in time it can occur, that they make an agreement that they will adhere to taking their medication when they're supposed to, and not using other medication for other purposes, that sort of thing. So the opioid agreements increased substantially, particularly for those on the chronic opioids, and urine toxicologies, that individuals were receiving a urine toxicology test at least once a year during that time period, and that's to validate whether people are using illicit opioids for the same thing. And so those things changed substantially over time, which is consistent with what you'd hope with a set of interventions that are designed to do these sorts of things. And so it suggests that that if you really put the effort in, you can see those changes. And so we've been interested in looking at that, which are the effective, most relevant components as we go forward.